Question 1. In a context of pediatric echocardiography, the accurate understanding of Doppler waveforms is essential for evaluating various cardiovascular conditions. An 8-year-old patient is undergoing an echocardiogram, and the Doppler waveform of the left ventricular outflow tract LVOT shows a prominent early systolic notch. Which of the following is the most likely cause of this finding? A. Severe aortic valve stenosis. B. Early systolic flow reversal due to mitral valve regurgitation. C. Normal physiological variation in children. D. Pulmonary valve stenosis. Answer. Correct answer. C. Normal physiological variation in children. Explanation. In pediatric echocardiography, it is common to observe an early systolic notch in the Doppler waveform of the LVOT as a normal physiological variation in children. This is typically seen in healthy children where the notch represents the rapid early systolic ejection and does not indicate pathology. The notch is often more pronounced in younger children due to the dynamic nature of their circulatory system. In contrast, significant conditions like aortic valve stenosis would produce a more sustained and altered Doppler waveform rather than a simple notch. Thus, it's crucial to distinguish normal variations from pathological findings by considering the age of the patient and other clinical indicators. Question 2. During a pediatric echocardiographic examination of a 3-month-old, the technician notices a hyperechoic structure in the right atrium. The structure does not appear to be mobile and is located near the interatrial septum. What is the most likely diagnosis? A. Atrial septal defect AST. B. Right atrial thrombus. C. Patent foramen overflow. D. Chiari network. Answer. Correct answer. D. Chiari network. Explanation. A Chiari network is a normal anatomical variant often seen in pediatric patients. It is a delicate web-like structure in the right atrium, typically located near the interatrial septum. The network is made up of thin strands of tissue and is usually hyperechoic on ultrasound. It is non-mobile and does not obstruct blood flow, distinguishing it from a thrombus or other pathological conditions. Atrial septal defects, as in patent foramen overflow, may be visible on echocardiography but present with different findings such as abnormal shunting or septal defects. The Chiari network is generally considered a benign finding and does not require treatment unless associated with other cardiovascular anomalies. Question 3. When considering the principles of ultrasound wave propagation, which of the following best explains why sound waves are attenuated as they travel through tissue in pediatric patients? A. Higher tissue density increases sound wave propagation speed, leading to greater attenuation. B. The scattering of sound waves due to tissue heterogeneity causes attenuation. C. High-frequency sound waves are absorbed by the tissue, leading to attenuation. D. Doppler effect causes a shift in frequency that results in attenuation. Answer. Correct answer. B. The scattering of sound waves due to tissue heterogeneity causes attenuation. Explanation. In pediatric echocardiography, sound waves are subjected to attenuation primarily due to scattering and absorption. The scattering occurs as the sound waves encounter varying tissue densities and structures within the body. In pediatric patients, the smaller size of the heart and other structures means that sound waves can interact with different types, which causes a reduction in signal strength as they travel deeper into the body. This attenuation is greater at higher frequencies, which is why low-frequency transducers are often used for deeper penetration, particularly in neonates and infants. While absorption and tissue density also contribute to attenuation, scattering plays a significant role in reducing the strength of the signal as it travels through tissue. Question 4. A pediatric echocardiogram reveals that a 5-year-old patient has a persistently elevated tricuspid regurgitation velocity with a peak of 4 meters. Based on this information, what is the most likely diagnosis? A. Normal right heart function. B. Pulmonary hypertension. C. Aortic valve stenosis. D. Mitral valve regurgitation. Answer. Correct answer. B. Pulmonary hypertension. Explanation. A tricuspid regurgitation velocity of 4 meters is indicative of significant pulmonary artery pressure, which can be a sign of pulmonary hypertension. Pulmonary hypertension in children can result from a variety of congenital and acquired conditions. In echocardiography, the velocity of the tricuspid regurgitation jet can be used to estimate pulmonary artery pressure (PAP) with value above 3.4 meters suggesting elevated pressures. This is typically seen in cases of pulmonary hypertension, which can be secondary to conditions such as congenital heart defects, pulmonary vascular diseases, or chronic respiratory conditions. Aortic valve stenosis and mitral regurgitation do not directly affect tricuspid regurgitation velocity in this way. Question 5. Given the circumstances, a pediatric patient is diagnosed with aortic coarctation and the echocardiogram shows significant left ventricular hypertrophy, what would be the most appropriate next step in management? A. Initiate medical therapy with antihypertensives and observe. B. Schedule the patient for aortic valve replacement. C. Proceed with balloon angioplasty or surgical repair of the coarctation. D. Recommend close follow-up with annual echocardiograms. Answer. Correct answer. C. Proceed with balloon angioplasty or surgical repair of the coarctation. Explanation. Aortic coarctation is a congenital narrowing of the aorta that can lead to left ventricular hypertrophy (LVH) due to increased afterload. Treatment typically involves either balloon angioplasty or surgical repair to relieve the narrowing and reduce the strain on the left ventricle. Medical therapy alone is not sufficient to address the obstruction caused by the coarctation, and it does not resolve the underlying pathology. Aortic valve replacement is unnecessary in this case unless there is concomitant valvular pathology. Close follow-up is important, but the primary intervention is either angioplasty or surgical correction, which directly addresses the coarctation and prevents long-term complications like heart failure and stroke. Question 6. The general consensus is that optimizing image quality during a pediatric echocardiogram requires careful adjustment of the transducer. Which of the following factors is most critical in determining the appropriate frequency for imaging a pediatric patient's heart? A. The patient's age and size. B. The presence of heart disease. C. The position of the transducer. D. The time of day the scan is performed. Answer. Correct answer. A. The patient's age and size. Explanation. The appropriate frequency of the ultrasound transducer is primarily determined by the age and size of the pediatric patient. Higher frequency transducers provide better resolution but have limited penetration, which makes them suitable for imaging smaller structures in infants or neonates. Low frequency transducers are used for older children and adolescents as they provide deeper penetration at the expense of resolution. The presence of heart disease does not directly determine the transducer frequency. However, it may influence the need for specialized imaging techniques or views. The position of the transducer and the time of day are not significant factors in determining frequency selection. Question 7. What would happen if the Doppler angle in a pediatric echocardiogram was incorrectly set at a value that is far from the optimal 020 degrees? A. Accurate flow velocity measurements would still be obtained. B. The Doppler waveform would appear overly damped and distorted. C. Flow direction measurements would become inaccurate. D. There would be no noticeable effect on the Doppler analysis. Answer. Correct answer. B. The Doppler waveform would appear overly damped and distorted. Explanation. When the Doppler angle is not set within the optimal range of 020 degrees, the measurement of velocity is affected by a phenomenon known as the cosine error. This results in an inaccurate estimation of the flow velocity, and the Doppler waveform may appear damped, with less distinct peak velocities and overall distortion. The incorrect angle leads to loss of sensitivity and can mislead the interpretation of cardiac function, particularly when measuring pressure gradients or shunt velocities. Proper angle alignment is essential for accurate Doppler analysis, and any deviation can cause significant errors in clinical decision-making. Question 8. During a pediatric echocardiogram, a 6-month-old infant shows an irregularly shaped ventricular septal defect (VSD) with a high-velocity shunt. The Doppler study indicates that the pressure gradient across the defect is 8 mHg. What is the most likely consequence of this finding? A. Normal VSD with no clinical significance. B. Pulmonary hypertension and risk of right-sided heart failure. C. Increased systemic vascular resistance and left ventricular failure. D. Complete resolution of the VSD with normal growth. Answer. Correct answer. B. Pulmonary hypertension and risk of right-sided heart failure. Explanation. A high-velocity shunt with a pressure gradient of 8m8G cross a ventricular septal defect (VSD) indicates significant left-to-right shunting, which can lead to pulmonary hypertension. The elevated pressure in the pulmonary circulation increases the workload on the right side of the heart, potentially leading to right-sided heart failure. Over time, untreated high-pressure VSDs can cause irreversible damage to the pulmonary vasculature, resulting in pulmonary vascular disease. While some small VSDs may close spontaneously, those with high-pressure gradients require close monitoring and potentially surgical intervention to prevent long-term complications. Question 9. The effectiveness of Doppler ultrasound in detecting congenital heart defects is crucial for early intervention. What is the primary advantage of using color Doppler in pediatric echocardiography? A. It provides a static image of the heart structure. B. It allows for precise measurement of blood flow velocities. C. It highlights blood flow patterns and abnormal shunts in real time. D. It is primarily used for measuring tissue elasticity. Answer. Correct answer. C. It highlights blood flow patterns and abnormal shunts in real time. Explanation. Color Doppler is invaluable in pediatric echocardiography because it provides real-time visual representation of blood flow patterns, including abnormal shunts, turbulence, and regurgitation. The color mapping allows clinicians to quickly identify areas of abnormal blood flow, such as in congenital heart defects like atrial or ventricular defects. This makes it easier to detect clinically significant conditions such as patent ductus arteriosus or coarctation of the aorta. While other Doppler techniques like pulsed and continuous wave Doppler are used for measuring velocities, color Doppler's primary role is to visualize flow dynamics. Question 10. In what ways can transducer manipulation affect the image quality during a pediatric echocardiogram? A. Altering the position can improve resolution but may compromise depth penetration. B. Increasing the transducer frequency always improves image resolution. C. The transducer angle has no impact on image quality. D. Moving the transducer does not influence the overall diagnostic value of the scan. Answer. Correct answer. A. Altering the position can improve resolution but may compromise depth penetration. Explanation. Transducer manipulation is a critical factor in obtaining high-quality images during pediatric echocardiography. By adjusting the position, orientation, and pressure applied to the transducer, the technician can improve resolution for better visualization of fine details like valve morphology or septal defects. However, there is a trade-off between resolution and penetration. Higher frequencies improve resolution but reduce depth penetration, making them ideal for imaging superficial structures in infants or neonates. Conversely, low frequencies penetrate deeper but at the cost of resolution. Therefore, careful consideration of the patient's size, age, and clinical needs is essential when adjusting the transducer to balance these factors effectively. Question 11. From a practical standpoint, the pediatric echocardiographer is performing an exam on a neonate presenting with respiratory distress. The initial TWAD imaging suggests situs solitis levocardia and a structurally normal atrial and ventricular arrangement. However, color Doppler evaluation of the systemic venous return shows a discrepancy. The IFC and SVC do not appear to connect to the right atrium. Further imaging reveals that IFC and VC drain into a left-sided atrium, with the most likely diagnosis A. Left atrial isomerism, B. Total anomalous pulmonary venous return, C. Truncus arteriosus, D. Double outlet right ventricle. Answer. Correct answer. A. Left atrial isomerism. Explanation. Left atrial isomerism is associated with bilateral left-sided morphology, often resulting in both veni cava draining into an atrium with left-sided features. This contrasts with the normal configuration where systemic veins drain into the morphologic right atrium. The segmental approach to echocardiographic analysis helps in identifying this abnormality. According to the AS Guide, for segmental analysis of congenital heart disease, systemic venous anomalies are a hallmark feature in isomerism syndromes. Other options like TAPVA involve pulmonary venous misrouting, not systemic venous return, and truncus arteriosus or DORF involve outflow tract anomalies rather than systemic venous connection. Question 12. To determine whether an increase in transvalvular velocity EWR is clinically significant, a pediatric sonographer must accurately interpret the pressure gradient across a valve. Which Doppler-derived measurement provides the most reliable estimate of the pressure gradient? A. Velocity time interval VTR. B. Mean velocity over the valve. C. Bernoulli equation D equals 4. D. Pressure half-time. Answer. Correct answer C. Bernoulli equation equals 4. Explanation. The simplified Bernoulli equation is essential for estimating pressure gradients in echocardiography. It converts measured velocity V into pressure gradient dP, where D equals 4. This is most useful in assessing stenotic lesions and evaluating hemodynamic severity. VTI reflects flow over time but not pressure. Pressure half-time is more specific to stenosis severity and not applicable to all valves. A mean velocity is descriptive metric and not pressure estimator. ARDMS standards emphasize correct use of Doppler principles in deriving hemodynamic values. Question 13. In light of recent developments, a 3-month-old with suspected coarctation of the aorta is undergoing echocardiographic evaluation. The echocardiographer uses color Doppler and sees aliasing at the aortic isthmus. To further quantify the obstruction, which Doppler technique should be prioritized for the most accurate peak gradient assessment? A. M-mode Doppler. B. Pulsed wave Doppler at the suprasternal notch. C. Continuous wave Doppler aligned with descending aortic flow. D. Color M-mode tracing. Answer. Correct answer C. Continuous wave Doppler aligned with descending aortic flow. Explanation. Continuous wave Doppler AW allows accurate assessment of high velocity flow across areas of obstruction like aortic coarctation, aligning the subdubulum with the descending aorta, especially from suprasternal notch or high parasternal window, permits the best estimation of peak velocity and thus peak pressure gradient. AW is limited. Aliasing and cannot sample high velocities accurately. M-mode and color M-mode are not designed for measuring velocity gradients. The AS Pediatric guidelines strongly recommend EWR for pressure gradient estimation in stenotic lesions. Question 14. Considering the evidence, a pediatric patient with a known large ventricular septal defect (BSD) is being evaluated for pulmonary hypertension. What echocardiographic Doppler finding would best suggest elevated pulmonary artery pressure? A. Holodiastolic flow reversal in the abdominal aorta. B. Elevated tricuspid regurgitant jet velocity. C. Increased D. A ratio at the mitral valve. D. Shortened isovolumic relaxation time. Answer. Correct answer B. Elevated tricuspid regurgitant jet velocity. Explanation. Jet velocity is widely accepted as the most reliable non-invasive estimate of right ventricular systolic pressure of ESP, which reflects pulmonary artery pressure in the absence of RV outflow obstruction. By applying the Bernoulli equation to the velocity, echocardiographers can calculate RVSP, offering a reliable method to assess pulmonary hypertension. Other options may provide indirect signs, e.g., if it's shortening or aortic flow reversal. They are not specific or sensitive enough in isolation. Yass and ARDMS stressed the importance of velocity in pulmonary hypertension screening. Question 15. While examining the spectral Doppler waveform of the mitral valve in a 10-year-old child, the echocardiographer notes a tall E wave, diminished wave, and a short deceleration time, which underlying physiological abnormality is most consistent with this pattern. A. Impaired relaxation. B. Normal diastolic function. C. Restrictive filling. D. Pseudonormal filling. Answer. Correct answer C. Restrictive filling. Explanation. Restrictive filling is characterized by rapid early diastolic filling, tall E wave, reduced atrial contraction, smaller wave, and a shortened deceleration time. This pattern is a hallmark of advanced diastolic dysfunction, typically seen in restrictive cardiomyopathies or in elevated left atrial pressure. Impaired relaxation would show a reversed pattern, low E, tall A, while pseudonormal may normal but will change with prolonged reduction. AS guidelines for diastolic function emphasize tissue Doppler and pulmonary venous flow to differentiate these conditions in pediatric patients. Question 16. Through careful analysis of imaging artifacts in pediatric echocardiography, which of the following is A distinguishing feature of a reverberation artifact: A. It shifts with patient respiration. B. It appears as multiple equally spaced linear echoes. C. It causes color Doppler aliasing. D. It results from mirror image reflection across a strong reflector. Answer. Correct answer: B. It appears as multiple equally spaced linear echoes. Explanation: reverberation artifacts occur when ultrasound waves bounce between two strong reflectors, producing multiple equally spaced lines that do not represent real anatomical structures. They are typically seen near interfaces such as ribs, pericardium, or catheters. Mirror artifacts result from strong reflectors like the diaphragm. The color Doppler aliasing is velocity exceeding the Nyquist limit, and respiration-related artifacts are dynamic. Recognizing these is vital for image interpretation and avoiding misdiagnosis. ARDMS and AS training standards require familiarity with ultrasound physics to distinguish these artifacts. Question 17. When faced with a technically challenging window during a neonatal echocardiogram, the sonographer considers switching the transducer. Which of the following probes is most suitable for high-resolution imaging in neonates due to its frequency characteristics? A. 2 MHz phased array. B. 5 MHz convex array. C. 7.5 MHz linear array. D. 12 MHz phased array. Answer. Correct answer: D. 12 MHz phased array. Explanation: high-frequency transducers like 12 MHz provide superior resolution at shallow depths, which is ideal for neonates and infants with smaller thoracic anatomy. A phased array probe also allows for sector scanning critical and limited acoustic windows. Low-frequency transducers 2.5 MHz offer better penetration but poorer resolution, which is unnecessary. Superficial cardiac structures in neonates. According to ARDMS guidelines, transducer selection should consider frequency, field of view, and patient size for optimal image quality. Question 18. In comparison with adult echocardiography, which unique physiological conditions should be accounted for when performing fetal echocardiography? A. Presence of a foramen ovale. B. Aortic isthmus narrowing. C. Prominent pulmonary venous flow. D. Mitral annular calcification. Answer. Correct answer: A. Presence of a foramen ovale. Explanation: the foramen ovale is a normal part of fetal circulation, allowing blood to shunt from the right atrium to the left atrium, bypassing the non-functional fetal lungs. This is physiologic in utero and closes after birth. In contrast, mitral annular calcification is not a fetal condition. Of pulmonary venous flow is minimal in utero, and the aortic isthmus is narrow physiologically, not pathological unless associated with coarctation. Understanding fetal circulation is vital for pediatric echocardiographers, as emphasized in ARDMS fetal echo training modules. Question 19. Among the various acoustic properties important for ultrasound imaging, which parameter most directly influences axial resolution? A. Beam width. B. Pulse repetition frequency. C. Transducer frequency. D. Frame rate. Answer. Correct answer: C. Transducer frequency. Explanation: axial resolution. The ability to distinguish two structures along the beam axis is primarily determined by the spatial pulse length, which is inversely related to transducer frequency. Higher frequencies result in shorter wavelengths and better axial resolution. Beam width affects lateral resolution. Of influences Doppler sampling and frame rate impacts temporal resolution. Mastery of resolution principles is fundamental in the ARDMS P exam and essential for producing diagnostic quality images. Question 20. As a result of poor image quality during transthoracic echocardiography in a 2-year-old post-operative patient, the sonographer decides to optimize settings. Which ultrasound system control would primarily enhance near-field resolution without increasing tissue penetration? A. Decrease frequency. B. Increase overall gain. C. Focus the beam at the region of interest. D. Use a lower dynamic range. Answer. Correct answer: C. Focus the beam at the region of interest. Explanation: adjusting the focal zone to the region of interest improves lateral resolution by narrowing the beam width at that depth. This is particularly helpful in the near field where detailed imaging is required. Lowering frequency would improve penetration but reduce resolution, increasing gain affects brightness but not sharpness, and reducing dynamic range increases contrast but may subtle details. ARDMS emphasize the strategic use of machine controls for optimal pediatric imaging. Question 21. During a routine follow-up, a 7-year-old child with a history of repaired tetralogy of Fowler TOF is undergoing a transthoracic echocardiogram. The sonographer detects a wide pulmonary regurgitation jet extending into diastole with a deceleration slope approaching the baseline rapidly. Which hemodynamic issue does this most likely indicate? A. Pulmonary valve endocarditis. B. Pulmonary hypertension. C. Severe pulmonary regurgitation. D. Supravalvular pulmonary stenosis. Answer. Correct answer C. Severe pulmonary regurgitation. Explanation. In patients post-TOV repair, chronic pulmonary regurgitation is a known complication. A rapidly decelerating diastolic flow signal on Doppler indicates a significant pressure gradient between the pulmonary artery and RV, suggesting severe regurgitation. The slope of the jet correlates with severity. Pulmonary valve endocarditis is rare and typically associated with agitations. A pulmonary hypertension would show increased pulse pressures with decreased compliance, not necessarily rapid deceleration. And supravalvular stenosis affects systolic flow. AS guidelines recommend Doppler assessment of regurgitant jet characteristics to estimate severity. Question 22. A neonate presents with cyanosis and echocardiography shows a large atrial septal defect, a common atrioventricular valve, and a single ventricular chamber with both great arteries arising from it. What congenital defect does this most likely describe? A. Tricuspid atresia. B. Double inlet left ventricle. C. Common atrium. D. Single ventricle physiology, univentricular heart. Answer. Correct answer D. Single ventricle physiology, univentricular heart. Explanation. The univentricular heart is a severe form of congenital heart disease where both atria connect to a single ventricular chamber and typically both great arteries arise from that chamber. This scenario suggests a common atrioventricular connection in univentricular physiology. Double inlet left ventricle is a subset but not fully descriptive. Presentation. Tricuspid atresia features a hypoplastic RV and an intact IBS. According to ARDMS pediatric echo standards, a segmental approach is essential in such complex defects. Question 23. In assessing right ventricular function in a pediatric patient with suspected pulmonary hypertension, which echocardiographic measurement provides a reliable index of RV systolic function? A. Left ventricular outflow tract ETI. B. TAPS tricuspid annular plane systolic excursion. C. Mitral annular E ratio. D. Aortic acceleration time. Answer. Correct answer B. TAPS. Explanation. TAPS is a simple reproducible M-mode measurement used to assess RV longitudinal systolic function. A reduced TAPS indicates impaired RV function, which is particularly important in pulmonary hypertension. Ovid ETI measures systemic output and is not RV specific. Mitral E relates to LV diastolic function, and aortic acceleration time pertains to systemic vascular resistance. AS guidelines for pediatric echoes stress the utility of TAPS and tissue Doppler indices in evaluating RV function. Question 24. During fetal echocardiography, the sonographer observes reversed flow in the ductus venosus during atrial contraction. What conditions should be most strongly suspected? A. Hypoplastic left heart syndrome. B. Fetal anemia. C. Increased right atrial pressure. D. Supraventricular tachycardia. Answer. Correct answer C. Increased right atrial pressure. Explanation. Reversed away flow in the ductus venosus during atrial contraction is a sign of elevated right atrial pressure or decreased compliance of the fetal heart. This is commonly associated with cardiac dysfunction or congenital anomalies. It may be seen in severe cases at AHHS, but is a nonspecific sign. Fetal anemia would show hyperdynamic circulation, not reversal. AE cause high drops, but not this Doppler pattern specifically. Issue organ as fetal echo guidelines recognize DV reversal as a key indicator of abnormal fetal hemodynamics. Question 25. When performing a peristomal on-axis view, the aortic root appears dilated in a 14-year-old with Marfan syndrome. Which measurement parameter is used to confirm abnormal aortic root size? A. Z-score adjusted for age and body surface area. B. Absolute diameter in centimeters. C. Mean systolic gradient across the valve. D. Indexed left atrial dimension. Answer. Correct answer. A. Z-score adjusted for age and body surface area. Explanation. Z-scores account for a child's body surface area and are used to standardize aortic dimensions in pediatrics. This ensures that size is interpreted in the context of the child's growth. In connective tissue disorders like Marfan, even slight enlargement with high Z-score is clinically significant. Absolute values are insufficient in pediatrics due to body size variation, as pediatric echo guidelines specify Z-scores for evaluating aortic root and LV size. Question 26. A 5-year-old with no known heart disease presents with a new systolic murmur. The echocardiogram reveals turbulent flow at the left ventricular outflow tract with a peak velocity of 2.8 meters. What is the estimated pressure gradient across this area? A. 8 mmHg. B. 16 mmHg. C. 13 mmHg. D. 50 mmHg. Answer. Correct answer. D. 30 mmHg. Explanation. Using the simplified Bernoulli equation, E equals 4, velocity of 2.8 meters gives pressure gradient of approximately 4x 2.8 total 31.30 mmHg. This is consistent with mild to moderate obstruction. Recognizing how to apply Doppler physics is critical in pediatric echocardiography, as reinforced in ARDMS exam content and technical standards. Question 27. A pediatric echo reveals an eccentric mitral regurgitation jet directed anteriorly toward the interatrial septum. Which underlying lesion is most likely? A. Rheumatic mitral stenosis. B. Posterior mitral leaflet prolapse. C. Anterior mitral leaflet flail. D. Parachute mitral valve. Answer. Correct answer. B. Posterior mitral leaflet prolapse. Explanation. In posterior mitral leaflet prolapse, the regurgitant jet is directed anteriorly, striking the interatrial septum. The direction of the Mr. Jet helps identify the involved leaflet. An anterior leaflet flail would direct the jet posteriorly. Rheumatic stenosis results in restricted motion and central jets. Parachute mitral valve involves single papillary muscle insertion, causing stenosis more than regurgitation. AS guidelines emphasize jet direction as a clue to leaflet pathology. Question 20. When evaluating a patient with suspected coronary artery origin anomaly, which echocardiographic view is most helpful in visualizing the coronary ostia? A. Apical four-chamber view. B. Subostal sagittal view. C. Parasternal short axis at the level of the aortic valve. D. Suprasternal on axis. Answer. Correct answer. C. Parasternal short axis at the level of the aortic valve. Explanation. This view best demonstrates the origin of the left and right coronary arteries from their respective sinuses. It is essential in evaluating conditions like anomalous origin of the coronary artery from the opposite sinus, Al-Kappa, R-Kappa. Other views do not reliably show the coronary ostia, as pediatric echo protocols designate this view as critical for coronary assessment. Question 29. A 9-year-old child with signs of systemic venous congestion is undergoing an echocardiogram. The IVC is plethoric with minimal collapse on inspiration. What does this finding most likely indicate? A. Hypovolemia. B. Elevated right atrial pressure. C. Pulmonary valve regurgitation. D. Normal volume status. Answer. Correct answer. B. Elevated right atrial pressure. Explanation. A plethoric dilated IVC with reduced respiratory variation suggests elevated right atrial pressure in normal children. The IVC collapses with inspiration due to negative intrathoracic pressure. Lack of this variation correlates with increased central venous pressure. ARDMS standards for cardiac echo identify this as a non-invasive surrogate for raw pressure estimation. Question 30. In a post-op patient with a blalotoxic shunt, the Doppler study shows continuous flow in the right pulmonary artery. What does this finding suggest? A. Closure of the shunt. B. Normal shunt patency. C. High pressure in pulmonary artery. D. Branch pulmonary artery stenosis. Answer. Correct answer B. Normal shunt patency. Explanation. A blaloktosic BT shunt connects the subclavian artery to a pulmonary artery to provide pulmonary blood flow in cyanotic defects. Continuous forward flow into the part on Doppler confirms patency. Absence of flow may suggest thrombosis or closure. High pressure might show retrograde or bidirectional flow, and stenosis would cause turbulent flow. According to congenital heart disease echo protocols, assessing shunt flow is essential postoperatively.